Hi, everybody. This time we're going to talk about, we're going to talk about evaluating and assessing the patient. So I'm not talking about assessment, diagnosing. So we already talked about diagnosing in the other slide set, but now we're going to talk about how you're going to do the medical evaluation on the initial visit as well as subsequent visits. So we want to think about treating diabetes as a team effort between the patient, you, and as well as wherever we refer out. These are the main goals of care to help manage this person's diabetes. So if we go into more detail here, we look at the first one, which is the patient's characteristics. We need to get to know the patient. So what is their lifestyle? What other comorbidities do they have? And what are their clinical characteristics, their age, weight, hemoglobin A1C, other labs. How's their motivation and depression? Because remember, many patients with disease in general have issues with depression, and it's not surprising, as well as their cultural and socioeconomic context. So I know that all of you as nurses, we were taught holistically, so I have no doubt that you would continue that. And so we just get to know the patients. And that may take a few visits if it's just your first time seeing the patient. So, all right, consider specific factors that impact the choice of treatment is next. So, remember if this patient's obese, if they have hypoglycemic issues, if they're on certain medications, what's the complexity of what they're taking, what's the cost, access. So, as you can see, as you're taking care of this patient, all these things are in the back of your mind. So if I'm prescribing a medication, I'm always thinking about the cost. And that's just how it is. Insurance companies really drive how we are prescribing. And I think it is unfortunate. That's just my opinion, though, because I feel like some patients would benefit better from certain medications, but yet their insurance won't cover it. So hopefully it'll get better as time goes on. Shared decision making, making sure that you and the patient are on the same page. Management plan, and you guys know all about SMART goals, right? Because I think you have to do those for clinicals. But SMART goals are really important, and it just needs to be specific. You're going to check your blood sugar in the morning when you wake up before you eat breakfast every single day, and you're going to record it on your blood sugar log. That's just one example. So it's specific. Then you're going to implement the management plan. And now I say, and this is the guidelines, they should be seen at least every 3 months. As long as progress is being made, then it could be less frequent. So if they're not meeting the goals, you need closer follow-up. And I really am happy about the type of care that's happening now, where sometimes you can email them. I mean, I have patients email me their blood sugar log. Some people have a deductible. A lot of people have high deductibles. So I'm fine with them sending me their glucose test after a week if I'm really watching them. And of course, we're going to do ongoing monitoring and support and checking everything and review and agree on the management plan. So we're going to go through all of that stuff. So the comprehensive medical evaluation, this is the initial visit. You want to confirm the diagnosis, classify the diabetes. So whether you had a fasting blood sugar before and now you confirmed it, or they had an A1C that falls within that range, you can diagnose them with that. You're always going to evaluate them for complications. Do they have any macro or microvascular complications, comorbid issues, any other comorbid issues, high cholesterol, past hypertension history, etc. You're going to look at all the previous treatment and risk factors with already established diabetes, and you're going to talk about having a plan. So for the follow-up visit, has most of the components of the initial visit, but you're also going to have more going over labs with them and just more of that continuity of care. And I'm going to show you a table in just a minute that shows that. And this shows the importance of immunization, so don't forget about pneumococcal, the Prevnar, Pneumovax, the yearly flu shots, and hepatitis B if they haven't had it, because remember, these people are more prone to illness. All right, now here is the components of the medical evaluation, and it gives you a table, which I love tables: initial visit, every follow-up visit, and annual. Now these are guidelines. Remember, we say guidelines are written in pencil or erasable pen because you have to tailor it to the patient. So sometimes you will do more of an assessment at the every follow-up visit. But as you can see, the initial visit, you need to get that history, including the family history, and what other comorbidities do they have, as well as are they obese? Do they have sleep apnea? Do they have hypoglycemic issues? Do they have any anemia, blood pressure, lipid issues? When was their last dental visit? Eye exam for retinopathy, and visit to specialists if they have had any changes. Also, eating patterns, weight history, physical activity, how are they sleeping? Are they at risk for obstructive sleep apnea? If they are, do the STOP-BANG, STOP-BANG screening tool for patients. That is very important that we don't miss sleep apnea because that can help improve their other comorbidities such as hypertension. Tobacco, alcohol, and substance abuse, and what medications are they taking, as well as how are they with technology? Do you think they can handle things or not, as well as what do they have? And the initial visit, you probably are going to have to get them set up with that. And something to remember, which you probably already know, that the meters are usually very inexpensive. It's the strips that are expensive. So that's something to keep in mind. At Walmart, actually every pharmacy now, you can get their own brand name strips and meter. So for example, my insurance will only pay for so many strips for me, but I'm very careful about controlling my diabetes, and so I do what's called eat to your meter. So if I want to try, let's say, a half an apple, and I check my blood sugar before, and then I'll check it afterwards, but then I use up all my strips, so I have an extra meter that I get at, I have a Walmart one, and they have their strips. Now, can everybody afford it? No, but it is a little bit less expensive for those that can, and it's good to have those on hand. Psychosocial issues, diabetes self-management, you need to refer them, but this tells you exactly when you should refer them. All right, so how are we going to do our, now we're on the objective portion of our, of our SOAP note. So your physical exam, things that you should always do and things that you can not do at every follow-up visit. So for example, it looks like every follow-up visit it's more focused, but yet again, if it's abnormal, if somebody has an issue with peripheral arterial disease, if you're looking right here, let's see if I can get my thing working here. So, whoops, do that. So if somebody has peripheral arterial disease, you're going to check them at every follow-up visit. So then that would be in that box. And that's something to remember with these. These are guidelines. Are you going to get penalized for doing more? No. But just understand the important things that you need to have in that initial visit, and as well as guidelines in an annual visit. But if you're seeing them in between, which is usually every 3 to 6 months, you can tailor it. You need to tailor it to your patients. So, for example, every 6 months, I always get an A1C, but I always get a lipid profile. If their urinary microalbumin is abnormal, you should still repeat it, or I do. But again, these are recommended by the guidelines. The A1C you should get every 3 months. But if someone has hyperlipidemia and you put them on a statin, you don't want to go a whole year before you check them again. So you are going to check that. And remember, diabetes overlaps with a lot of different a lot of different comorbidities, including hypertension and high cholesterol and thyroid issues. There's also different organizations that give you different recommendations. So while the American Academy of Endocrinologists, the ACE guidelines, has their own separate from this, which is the American Diabetes Association, but it's, I would say, almost to the T alike. So there's really not that many dissimilarities with it. One thing to know is if they're on metformin, you should get a B12 level. And again, yeah, unless they're abnormal, it doesn't need to be checked every time they come in. But those on metformin it's more uncommon, but it can happen, have a B12 deficiency. The TSH, if they have hypothyroidism and it's well controlled, you're going to get it every year. If it's not, and you need to make a medication adjustment, then you aren't going to skip this. Then you are going to check in 8 weeks, most likely. So I hope I don't confuse you, but just remember, comprehensive, tailored to the patient, working together as a team. If there's abnormal. Okay, so this gives you an assessment and treatment plan. These are just taken from the guidelines. So you need to assess the risk of diabetes complications. You need to set the goal with the patient, and then you have a treatment plan with the patient. And I'm going to go over all of these more in detail in the different sections. But just so you know, as we are doing this diagnosing, we talked about diagnosing, we talked about doing the medical evaluation, which means your physical exam and getting your family history. So we're doing the subjective portion and we're doing the beginning of the objective portion of the plan. This here is an overview. So again, you're assessing for comorbidities, including atherosclerotic cardiovascular disease, ASCVD, and heart failure history, risk factors. Do they have chronic kidney disease? Because remember, they can have microvascular complications, nephropathy from having diabetes. Hypoglycemia risk. So when I think of diabetes, and I know it scares patients, but it really does scare them into taking care of themselves, I tell them that sugar, you're really only supposed to have 1 teaspoon of sugar a day. Your body does not like having more sugar. Sugar, to me, is just toxic. And our food is inundated with it. So if people have too much sugar and it's circulating around your bloodstream because your pancreas is not able to secrete the insulin that it can, and your cells aren't able to even bring the insulin in to help get rid of the glucose, it sits in your bloodstream. And I think of it as little tiny glass shards running through your bloodstream and doing damage all over the place. It's getting in your nerve endings. It's getting in small vessels, large vessels. Okay, so that's just my other soapbox. Goal setting. You set your A1C and blood glucose target. We're going to talk about that. If hypertension's present, what's the blood pressure target? And diabetes self-management goals. So we're going to talk about hypertension and all that stuff. And assessment of hypoglycemia risk. Again, more stringent or less stringent. So if you're elderly, we're not going to be as strict with their A1C because we don't want them having hypoglycemia. What if they are special needs? What if they, are otherwise unable to have any capability to take their medications how they should or have hypoglycemic issues? Also, not to forget polypharmacy. Are they on beta blockers, ACE inhibitors? Now, beta blockers can mask hypoglycemia. And then referrals. So eyes, family planning, their reproductive age, registered dietitian, diabetes education, dentist, and mental health professional if needed. There's some common comorbidities in patients with diabetes. If you have type 1, it's autoimmune, so you are more at risk for having other autoimmune issues. Cancer, obesity is actually related to an increased risk of breast cancer. Cognitive impairment and dementia. Think about all the blood sugars that are running around in your bloodstream. It goes to your brain too. You're at risk for stroke. Fatty liver disease. Obesity contributes to fatty liver disease and insulin resistance. Pancreatitis. Your pancreas becomes inflamed. Fractures, hearing impairment, HIV are common comorbidities. But this just doesn't mean you get HIV from diabetes. It means that those with HIV are at high risk for diabetes. So HIV, remember, years ago, we didn't have the treatment available like they do now. And so people died before they ended up having long-term consequences of HIV. Now we see the long-term consequences because we are able to treat HIV. They're actually thinking of taking the diagnosis AIDS away and just have it be HIV or some variant of that. So that can cause diabetes, high cholesterol issues. Low testosterone, obstructive sleep apnea, gum disease, and emotional issues. Autoimmune disease I talked about. We talked about this, talked about that, which is why you're going to check liver enzymes, which would be on a complete metabolic panel. Anybody with elevated liver enzymes, especially if it's 3 times above the upper limit, you should do a workup, which include, and this is a C recommendation, but in primary care, this is what I do. If they're on a statin, there are guidelines out there that say as long as they're below the 3 times upper limit of normal, you can just monitor and keep them on the statin, but you should test for hepatitis B and C to make sure you're not missing something, as well as get a liver ultrasound, and that will actually do the diagnosis. We also need to take fatty liver disease very seriously because that contributes to liver cirrhosis and increased risk of cancer down the road, as well as contributing to their insulin resistance. So we talked about HIV. HIV patients usually see specialists, but they will see their primary care in between for management. So if the screening tests are normal, you're just going to check them every year. Low testosterone. So if they have signs or symptoms of decreased libido, activity, erectile dysfunction, you can get a serum testosterone level to see how they're doing. Because remember, if diabetes, blood sugar is running through your bloodstream, macrovascular, microvascular complications, you can have erectile dysfunction because blood needs to get to the penis to actually, have a sexual intercourse. And so if that's not working, then that's when Viagra comes in and we think about, do they have vascular disease in other areas? And anxiety disorders and depression, we should be doing annual depression screenings. And I think a lot of places do them at every visit, but that's what's recommended is that, and referrals to mental health providers, because this has to do with lifestyle change, and it's all about behavior change. It's very difficult to change your behavior if you don't have any diagnosed depression issues. And so imagine being told that you had to change your complete lifestyle around, which includes your diet, and that's very difficult. And that is it on this section.